I want to welcome everybody to the Quality Improvement Initiative Showcase. We are very excited to be presenting this webinar and very excited that all of you are joining us. My name is Mary Beth Cox. I'm a Quality Improvement Coordinator at DBHDS in the Office of Clinical Quality Management. The purpose of this webinar is really to share and celebrate all the work that has been done as part of quality improvement initiatives. And we realized that others in the agency may not have heard of these QIIs, so we thought we would share it pretty widely. I am recording this webinar. I do plan to figure out how to post it somewhere. I also plan to share the slides with attendees following the webinar. The chat should be open, so you can put questions in there, but I'm going to save the questions for after all 6 of the presentations are done. I want to thank all of our presenters for being part of today's presentation, and I want to thank Ramona DeFonza for helping me with some of the behind-the-scenes work, so she's monitoring the chat and things like that. So before we get to the showcase presentations, which I know what you're all here for, I'm going to share some pieces of information that will help you better understand their presentations, put things in context, talk about our quality management system, some of the terminology you're going to hear, and the groups that we're going to talk about. So here we are. Let's start with some basics. What is quality? This definition is from Webster's Dictionary, and it defines quality as the standard of something as measured against other things of a similar kind, or the degree of excellence of something. So I think we can all relate to this in thinking about how our programs and services are evaluated against standards and expectations. It is also defined as a distinctive attribute or characteristic by someone or something. So we hear it used this way a lot. We can think of a statement like, we provide high quality services. That's a definition. Let's move to quality improvement, or QI. It has a few aspects important to its definition. It is an ongoing effort to achieve measurable improvement in just about any aspect of an organization, such as efficiency, effectiveness, performance, and outcomes. Furthermore, QI should include use of a model and a repeatable set of steps, supported by strategies, methods, and tools that work best if they are a routine part of your operation. So let's talk about the model for improvement. DBHDS has adopted the model for improvement as the QI framework that we use in the quality management system for doing quality improvement projects. The model starts by answering the 3 questions. So you can see those at the top here. What is your aim? What is your measure? And what is your change? Now there's quite a bit of work that goes into answering these questions. For example, collecting and using reliable data over time is critical to being able to set your aim or your goal and develop a measure. Also, doing a root cause analysis is important when you're trying to identify your change. Once you answer those questions, you enter into a plan, do, study, act cycle to figure out if your change worked. So very quickly in your plan phase, you map out how you're going to do the change. Then you do the change and record your observations. In the study phase, you evaluate your efforts. You ask, did it work? And then finally, you decide to adapt, adopt, or abandon your change. This is the cycle that all of our presenters and their teams have gone through for their projects. Let's look at our quality management structure for a moment. DBHDS has established the Developmental Disabilities Quality Improvement Committee here at the top as the highest quality committee for the DD quality management system. All the other subcommittees that you see here report to the Quality Improvement Committee. Currently, there are 11 subcommittees that each focus on a different area of the system. I want to point out that there are 5 regional quality councils, 1 in each region. I want you to really remember the acronym RQC, as you will be hearing from several RQCs, or Regional Quality Council chairs, today. You'll also be hearing from projects from the Risk Management Review Committee and the Case Management Steering Committee. And this is a map of the regions and the regional quality councils and their chairs. So let's talk now about quality improvement initiatives. You can tell we're getting closer to the meat of today's presentations. We define our quality improvement initiatives as strategies designed to support quality improvement activities that follow the PDSA cycle to seek improvements. We want to see improvements in systems and processes and outcomes, improve weaknesses, and prevent or mitigate the risk of harm. Each subcommittee that you just saw in the previous slide must submit or propose at least one QII every year. Each subcommittee uses a special toolkit to ensure that they walk through all the steps of the model for improvement. And since 2020, the subcommittees in total have done more than 40 QIIs. So today you're just going to hear about 6. Over the years, many people and groups have been involved in the QIIs. It's not possible to even list all of them. We tried, but we want to take this moment to thank everybody in these offices listed and beyond who have played a role. Thank you very much. Finally, I want to make sure that you leave with some resources to go further if you want to. On the external DBHDS website, we have some resources available to you, including a resource list of QI toolkits and trainings, a quality improvement job aid, a series of YouTube modules about quality improvement topics. And on the intranet, we have information about a monthly quality improvement webinar called Getting Started with Quality Improvement that I currently teach, Upskill, which is a data literacy training module, and the QII toolkit that I mentioned. So now to what you really came here for. Let's get started with the showcase. So we are going to start with Regional Quality Council 1's presentation. Let me just pull it up. So to share this presentation, we have Jamie Roop, who is the Quality Improvement Specialist for Region 1. Jamie?
Hello, everyone. Good morning. As Mary Beth said, thank you, Mary Beth. That was a great introduction. I'm Jamie Roop. I'm the Quality Improvement Specialist for Region 1, and I will be talking about the Electronic Home-Based Services Quality Improvement Initiative that we did for fiscal year 23. Next slide, Mary Beth. Or Ramona, whoever. So wanted to list off our people in our work group. I'm not going to read everybody's name, but I wanted to point out that we had a huge diverse population of people that had participated in our work group, which was really, really helpful as we move this work group forward. We had someone from Provider Network Supports. We had several members from our Regional Quality Council team that participated on this smaller work group. We also had 2 providers who did electronic home-based services who participated in this work group. And we also had 2 people from service authorizations that participated in this work group. So it gave us a great perspective on EHBS and the different facets of how that service worked and how it was approved. And it just gave us a really good idea of how to find out where the issues were with this service. We also had some offices who participated that may not have came into the work group necessarily, but we collaborated with them to during this QII, which was Provider Network Supports again, Office of Integrated Health, Hiram Davis Medical Center, DMAS, and then Hansel Union Consulting. Next slide, please. Okay, so a little bit of background about electronic home-based services. It offers remote supports to individuals through virtual means, as well as monitoring for risk factors dependent on individual specific needs. We landed on doing a quality improvement initiative because we saw there was a very low utilization rate for electronic home-based services, even though it had been established for several years. We also wondered if electronic home-based services could be utilized to assist with staffing issues, because those were very prevalent during this time period when we were looking at electronic home-based services and doing a quality improvement initiative. We completed a root cause analysis. We utilized a brainstorming session, an affinity diagram, a fishbone diagram, and a process map. And we identified some root causes. We identified that regulations for EHBS were really contributing to that service being difficult to obtain. And some examples of that were assessment requirements, who could provide the assessment was a big question, and low funding limits. So we decided to focus on another root cause due to regulations being difficult to address right away. Those can take a lot of time to make regulation changes. So we decided to look at something else to get started. So we focused on the bottleneck of people being able to get assessments to receive the electronic home-based services. And we learned, as I stated a little bit above, we learned that the regulations were confusing along with the process of how to obtain EHBS, all were contributing to the service not being utilized. Next slide. And so our model for improvement, our aim was to increase the use of electronic home-based services in Region 1 specifically by 80%. And when we started that out, we're like, wow, that 80% sounds really high. But in reality, it was only 10 individuals. Our baseline was 13. So we were trying to increase that to 23 individuals receiving the service in Region 1 by June of 2023. We used the provider data summary to measure that. That comes out about every 6 months. We were able to monitor that over time to monitor for any improvement in the data of individuals receiving electronic home-based services in Region 1. So our first change was we conducted a root cause analysis because we really wanted to understand why that service was not being utilized, because it sounded like a wonderful service, but yet it was not being utilized very heavily. The second change we tested was introducing resources to complete electronic home-based assessments to see if that reduced the number of individuals on wait lists for EHBS. And we'll talk a little bit more about the changes coming up. Next slide. All right, so what did we do? After we completed our root cause analysis, we wanted to focus on regulations because we thought that was one of the main barriers. But working towards changing regulations can be a lengthy process, and there's no guarantee that that change is going to be made. So one of the solutions that was presented to us was that 2 members from our QI group could participate on a DMAS focus group that was going to be started that was going to look at electronic home-based services. However, that was not going to start immediately. So that was kind of the thing that was in the background that we thought, hey, we can do that down the road to make an impact, but we don't think that focusing on the regulations right up front is going to be where we can have the most impact. So we decided instead to complete a process map, and we identified bottlenecks in the process of obtaining electronic home-based services. And that's where we landed with the biggest issue was trying to get assessments completed. And so the change that we asked our providers on our QI work group was to track their wait list using a run chart to see if there was any improvement. And while we were asking them to track those over time, we got together with the Office of Integrated Health to see if Hiram Davis Medical Center or Hansel Union Consulting could complete EHBS assessments to help with that bottleneck. Next slide. During that time, while all that was going on, we were continuously meeting, sometimes every 2 weeks, but at least once a month, talking about continuing to work on our QI and what was going on and what the barriers were and how we could address those. So those conversations continued to happen. Outside of our QI work group, there were also conversations happening with the EHBS providers, provider network supports, service authorizations, and DMAS. And ultimately, those conversations led to clarifications around obtaining the EHBS. So after receiving those clarifications, we figured out that our change was going to have to be abandoned because that process was no longer accurate, and we weren't able to track that because it wasn't following the true process of receiving electronic home-based services. So we did end up abandoning our second change. However, During that time, we realized that when we checked the provider data summary report, Region 1 had drastically improved their numbers in Region 1. And so we ended up ending the QII because there had been a lot of progress based on those clarifying conversations and work that had happened outside of just making the change within our quality improvement initiative. And fast forward to the end of 2024, I was talking with a EHBS provider, and they were very complimentary of the work that we had done and some of the tools that had came out since then. And I'll talk about those in just a minute. But they stated that that had been made it much easier to obtain electronic home-based services, and they attributed a lot of that to the work that was done in this quality improvement initiative work group. Next slide, please. All right, so just the numbers. In May of 21, like I said, our baseline was 13 for Region 1, and that's in that orangish, yellowish color under Region 1 there. In November of 2022, when we looked at the data summary report again, it was at 42 individuals. So that was actually a 223% increase. We thought 80% was high, but we hit 223%. So we were really happy about that. And that's when we decided that we would end the QII, but also knowing that these other conversations were already taking place and more individuals are already utilizing the service. Over time, in Region 1, you can see from May of 21, it went from 13 individuals, and May of 24, in the data summary report, it was up to 56, which is a great increase in Region 1. But you can see to the left of that column, there's the total number of EHBS that's statewide. It started at 40 in May of 21, and it was up to 187 in May of 2024. So very, very good progress as far as utilization of the service. Next slide, please. All right, and this is our process map. We started out, this took a lot of work, a lot of meetings, a lot of back and forth. We developed a process map and figured out where our bottlenecks were. Then we were able to take that process map and get it to Eric Williams, and he did a wonderful job on this, made it very visually appealing. And now this process map is available, and you can actually see this is the process for receiving electronic home-based services. There was some confusion about that based on regulations and all kinds of things that were going on previously. But now this is available that shows the true process map for obtaining electronic home-based services. Next slide, please. Another improvement that's came along with electronic home-based services is there's now an assessment that's specifically for electronic home-based services. We identified during our root cause analysis that it was unclear about who could provide assessments and what actually was being looked at during an assessment. So since that time, DBHDS has released a assessment tool specifically for electronic home-based services, and this was one of the tools that the electronic home-based services provider was very complimentary of and said that it had made a huge difference in individuals being able to receive the service. Next slide, please. Another change that has happened since we did this quality improvement initiative, we also identified this in our root cause analysis, is that there were 3 pots of money, assistive technology, electronic home-based services, and environmental modifications. And each of those were $5,000 a piece, and that used to be the limit, and it had to be used towards that service. Since that time, they've been combined, and so now someone could receive up to $15,000 for electronic home-based services, and that makes a difference in people being able to access funding to receive this service, rather when before it was much less. So that's been another positive change. Next slide, please. All right, then we get to our takeaways. The QI, the PDSA worksheet, we pulled that up every session that we met in our QI work group, and we walked through that to ensure that the group was responsible for talking through each of the areas, giving feedback, and it really kept everybody on track, and everybody was well aware of deadlines, but it also helped facilitate conversation because there's questions on there. It lays out what you need to look at, where are you heading? So that was always kind of our roadmap for staying on track as far as our QII. The second change in our QI, although it wasn't successful, the overall work that was done really paved the way for those important discussions and clarifications that ultimately assisted with this service becoming easier to obtain and being able to be provided. And then the third and my favorite one, and this is kind of where this started, the QI, this specific work group, I talk a lot with Brett about having the right people in the room. And we really have the right people in the room for this QI. We had all the different perspectives, and it really helped us get to the point where we were making a change with our QII. So that's really important, is having the right people in the room, making sure you're looking at all the different aspects of what you're focusing on. And next slide. And just some of the tools and resources. The PDSA worksheet, like I said, was very, very helpful. The root cause analysis, we utilized the brainstorming, affinity diagram, the fishbone diagram, and ultimately the process map. And then we asked our people to utilize a run chart. And that was our QI for Region 1.
All right. Thank you so much, Jamie. Um, that was a great presentation. I love all of these QIIs, but I love the story of you were trying to do this change here, but because of the work, you inspired some process improvements over there that also work to improve your outcome. So um, I think that's a really interesting take. And just for all of our attendees today, I asked each group to share the tools and resources with you so that, if you're like, oh, I want to know more about that specific tool, you can find it, or you can ask me and I can give you a template or a place to go learn more about that tool or resource. So I stopped sharing because our next presenter, Christy Lambert, is going to share her screen. Christy is the QI specialist in Region 3, and she's going to talk about um, a multi-group QII. Thanks, Christy.
Thank you, Mary Beth. Again, I'm Christy Lambert. I'm a Quality Improvement Specialist, Region 3 with DBHDS. And this QII is related to employment and integrated community involvement. And as Mary Beth said, this QII involved several groups. And I was a participant in a couple of those groups. So that's how I got to present this to you. But basically, there were three different groups that had looked at this particular topic, the Regional Quality Council in Region 2, Region 3, and the Case Management Steering Committee. And in addition to those three main groups, they built off of each other over the last 2 years on this topic. But they pulled in other groups of people. And I won't read through all these, but you've got your LMNOPs of your acronyms here to let you know that there was just a lot of people that were involved with each one of these efforts. A little background on the employment and integrated community involvement life areas. These were found to be important because they promote greater community involvement with smaller ratios of staff to individuals. And consistently, the data was showing that we were a little low in these areas, and each region identified that there were issues there. So that's where this entire topic got started. Once that was determined, once the data started showing that we weren't quite meeting where we wanted to be across the state, CSBs and private service providers started talking and saying, hey, we're confused about it. We don't understand when we're supposed to use it, when we're not supposed to use it, that type of thing. And then focus groups started to echo the same confusion. So that's why these topics were chosen for QIIs initially. Each group, the RQC2, RQC3, and Case Management Steering Committee, each one specified individual aims, but they were all really similar. For RQC2, their focus was on improving the percentage of ISPs in their region that had this specific type of outcome noted in their person-centered plan, sorry. And they use the quarterly case management WAMS data for the measures 6, 3, and 3B as their measure. And they did several different things, which we'll go into more detail in a few minutes, but they completed root cause analysis to try to figure out why those issues were lower in that area. And then they created some tangible fact sheets to use related to those life areas. Region 3 similarly wanted to increase the percentage of ISPs in Region 3 that had that same piece within the data. They used the same data to measure to see that they were lower than the target to begin with and to measure to see if they've had any improvement. And then their changes were to educate on what was already being shared that RQC2 had created and to have some in-person sessions to try to eliminate any apparent confusion that was still going on. And then the Case Management Steering Committee, again, they look at the entire state. So they're not looking at just one region. And they noticed that, yes, this measure was low everywhere. So their goal is to increase the percentage statewide using the exact same data. So looking at measures 6, 3, and 3B. And redistributing the fact sheets and really coming full circle with, hey, did you know this information was out there? And bringing the other regions into the fold where region 2 and 3 had been a targeted effort. So some of the things that were done with the different groups, RQC2 again started the role with doing root cause analysis and having focus groups. They really pulled people together to try to figure out the why and what was going on and why these numbers were so much lower. They created and published some fact sheets to help better explain the life areas that we were expecting people to note within their plans. And I think they were very helpful in letting people know that, we don't think of people as numbers, but we had to have a way to measure something. And so being able to say, hey, we have this data piece and it's the only way we know to look at this was very helpful there. They pulled in internal and external offices to try to get more input, and to get approval for published material to make sure that it made sense to everyone. RQC3 focused on promoting and clarifying those materials and making sure that people within their region knew that they existed, because RQC2 had put in the work and had published the information, but we didn't feel like the people in Region 3 knew it existed. So RQC3 focused on that. They had informal materials and presentations, informational materials and presentations that they had in person, because that area felt like that was part of the problem, that they were getting mixed messages and people really needed to hear the same message. So they pulled together DBHDS offices and pulled together support coordinators as well as private providers to make sure that everyone was in the room together hearing the same message. And then Case Management Steering Committee reviewed all the materials from the first two groups and then combined those to help make sure that it was coherent and that it was appropriate for the statewide effort. They have planned additional distribution of the information to include a video for individuals that possibly couldn't have made it to an in-person meeting. And then they will take ownership of those materials moving forward, so that if any changes need to be done or any uptake or upkeep to the materials, they'll be in charge of that. So Mary Beth had mentioned the PDSA cycle, and this just shows where each one of the groups fall within their PDSA cycle. Region 2, RQC, is pretty much done. They're just sitting back and enjoying the fruits of their labor at this point. And Region 3 is in their study period. They have 3 more sessions they're going to provide in another week from now. And then they will be looking at all of the data that's coming in. And the Case Management Steering Committee, again, is in the do stage. They're taking the lessons learned from the first 2 groups, and they're building on those right now statewide. Some results that have been seen. RQC2 and Region 2 saw improvements in the data across the region. They are now the leading region for that piece of data for those 3 measures that I talked about. So they saw great improvement, and it bumped them ahead of the other 4 regions of the state. RQC3 has not gotten the data based on their AIM statement yet, so they're still waiting on that. But they did do evaluations of the efforts to find out if it was helpful for the way it was presented and the materials that were presented within their region. And that information has been very positive coming back into them. So they have that piece of information at this point. And then, of course, the Case Management Steering Committee, they're still in the do phase. They've completed the video. It's being marketed in another week to the rest of the state. So they're still in that phase. So we're not sure quite yet where they stand. So some lessons that we learned along the way, and this is compiled from all 3 groups. One was to seek initial input and feedback from the external stakeholders, because sometimes you get too close to a situation and you don't know that there's a problem because you feel like everything's fine, but it's just because you're so close to it. So making sure to get that initial feedback from outside of DBHDS and from people that were not so involved in the situation was very helpful. And communicating why to create buy-in from other offices and groups. That was important. Again, when you talk about data, people feel like you're making everybody a number. And when you explain, hey, we think you're doing great work, but we can't prove that without this data, explaining that to people I know in Region 3, we saw some aha moments where they were like, oh, okay, I get it now. We're doing it, but there's no way for you to know we're doing it. So communicating that was extremely helpful. Encouraging collaboration between the multiple offices was huge with us. Um, as this project moved from group to group to group, more people were brought in and their input was brought in, and showing a shared message and making sure that providers knew that it was a shared message and we were all saying the same thing was extremely helpful. Having those resources in a variety of ways, because people learn in different ways. So we did have the in-person things, we had the meetings. There were some people that did not like having to come to an hour-long meeting just to get this information and wanted it in video format. There were some that were extremely appreciative of coming in person. There were some that just wanted the handouts and they were good. So offering it in a variety of ways showed to be very helpful. Not assuming that everyone that needed the information knew where it was, or had the information. It gets very easy to say, hey, go look on the website. And sometimes certain pages on the website read like stereo instructions. So we made sure in our presentations to not only say where people could find the information, but to give them QR codes and links so that they were able to find the information, and also to even show a picture of what the website looks like and where you click. And that was very helpful for a lot of providers that were like, I know it's here somewhere, but I don't know where. So making that assumption that everyone that needed it knew where it was would have been a mistake. And then again, making the materials simple and concrete, making them simple to read, simple to understand, and just as brief as needed to get the point across was very important. Some tools and resources used by all the groups. Focus groups was huge. We would definitely recommend that for collecting qualitative data. RQC2 led the way with that. They had family members. They reached out to external parties to get more participants, and that helped them to bring in a large range of people that had different opinions, but those opinions were important because in order to make sure that we truly understood the issue, we needed to hear from all of those different parties. RQC3 used its membership as a focus group. So they had membership from each of the catchments and different roles that were played, but it was a smaller group. So, knowing that focus groups are important, it's not as important to make sure that it's a formal process, but to make sure that there was a variety, or again, just like Jamie said, that the right people are at the table giving input. Some other logistical tips, we did use PowerPoint slides, handouts, videos, in-person presentations, all of that. But some other things that these groups used, we used Microsoft Bookings, which admittedly was a little tedious, but it did allow us to schedule limited seating sessions in different areas. It also would send out reminders and follow-up emails for us to the participants, which was helpful. We do give a word of caution. Don't make a big project your first project with MS Bookings. Make sure that you practice with it some first, because there are a lot of little nuances in it that you want to make sure that you get a handle on. We also used Microsoft Forms to capture evaluations of the sessions and of the materials. That has worked very well for short evaluations of sessions, for short feedback questions. Our advice is just to keep those questions concrete. Make sure that you have minimal rating questions if possible. If you can eliminate neutral, that's great. If you can't, that's fine too. But just making sure it's as short as possible to get the feedback that's important to you, but not discourage individuals from completing an evaluation. This is what the fact sheets look like that were created by RQC2 initially, and they are found on the DBHDS website. As you can see, very clear, like an executive summary, just to get the point across and to make sure that people have things bulleted to where they can understand what's going on with those different life areas. And again, this is how we shared the information within all of our handouts, including this one, is we included QR codes to get to each of the fact sheets. Within the handout notes sections are also the actual links to the web pages. So if you wanted to copy and paste the link versus using a QR code, then that was made available as well. And then we also gave instructions on where to find information on the website as to what page to click on and that type of thing. So those are just some of the tools and resources that we all utilized. And again, as Mary Beth said, there are some video series, and we would be amiss to say that we all used these. We've watched these videos and used the different root cause analysis tools that have been made available to us. And we just wanted to include this in our slides as well to say, hey, here's another resource in case you're looking for it, with the QR code and the link to find it, and to say, hey, these are very helpful. They helped us out. All three groups use this information to try to figure out the why and what was going on in our different regions. And we would recommend this to anyone else considering a QII. And that is it. We'll hand it back over to Mary Beth.
Okay, thank you, Christy. And if anybody watches those videos, you will hear a familiar voice, which is my voice. Yeah, and one thing I wanted to kind of point out about this project was the concept of spreading changes. So you start in one place, you test it out, achieve success, spread it to another place, and then this one is now being spread statewide. So that's another quality concept that I feel is illustrated with Christy's presentation. So thank you, Christy. Let me get this set up here. I do want to remind everybody, if you have questions, please put them in the chat. We definitely want to take advantage of having all of our presenters here to get your questions answered at the end. So with that, I'm going to introduce Pebbles Brown, who is the Quality Improvement Specialist in Region 4. She's going to talk about their improvement project around urinary tract infections. Pebbles?
Thank you, Mary Beth. Good morning, everyone. As Mary Beth stated, my name is Pebbles Brown, and I am the Quality Improvement Specialist for Region 4. I am presenting information on the Urinary Tract Infection UTI Quality Improvement Initiative. Next slide, please. As with all of our QIIs, we do have a vast array of people who are a part of it as far as our team. And so our team was comprised of DBHDS personnel from the Office of Clinical Quality Management, the Office of Integrated Health Support Network, Behavior Support Network, our Region 4 Quality Council members, Region 4 DD providers, along with some input from family members, individuals, and the DD staff. Next slide, please. So a background for this QII, in fiscal year 21, UTI serious incidents had continued to increase throughout the Commonwealth. So by Q2 of fiscal year 23, it had become the highest serious illness reported. During this time, Region 4 presented as the third highest number of reported UTIs in the Commonwealth. So in our root cause, the reasons for the increase were unknown. So we completed a quality improvement tool called a driver diagram to determine elements that might be contributing factors to the UTIs. After we did that, we utilized this information. We developed a questionnaire that we sent to DD providers in Region 4 to gain some more insight of the greatest needs and areas for potential interventions. So from their responses, we identified 4 areas of need, and they are hand hygiene, timely medical care, proper perineal care, and clean urine catch. Next slide, please. So this is the driver diagram we worked through. It starts on the left with our aim, which is to reduce the rate of UTIs. Next, what we do is we identify drivers that could help reduce the risk of the UTIs. What we do after that is we break it down even further into many other drivers and then identify potential changes or interventions. Next slide, please. So our model of improvement, first, our aim is to reduce the rate of reported UTIs statewide. So using a baseline data rate of UTIs from quarters 1 and 2 of fiscal year 23, we determined that a 5% decrease in reported UTIs was attainable. So with data obtained from the CRIS, we matched that with the WAMS data, and this allowed us to determine our measure with the rate of UTI serious incidents per 1,000 individuals with DD who received DD waiver per quarter. And then with the change, finally, we developed the Learning Collaborative, what is incorporating learning interventions with a DD providers serving individuals in group home and sponsored residential services. Next slide, please. So we had 5 DD providers participate in the Learning Collaborative. What we did was we conducted monthly webinars with trainings on the 4 interventions. We presented quality improvement tools like the Plan, Do, Study, Act cycle and various other quality improvement resources. The providers, what they did was submit monthly data of their reported UTIs, as well as giving us documentation of the utilization and the impact of the interventions as they were implemented in their agencies. Now, one of the barriers we did identify with our initiative was that while there were many providers who expressed initial interest being a part of the group, they may have not been able to commit for various reasons. And the commitment level for this QII was initially 6 months of monitoring and providing us with data, and it has since increased to a year, and I'll refer to that later on. Next slide. So these are pictures taken from our first training that was on proper hand hygiene, which was held at Richmond Behavioral Health Authority, better known to us as RBHA. They partnered with us and allowed us to utilize their facility for both our initial and our last training session. So we really appreciated their generosity and participation. Next slide, please. So as for our results, currently the aim has not yet been achieved, as any realized impact from our interventions have been limited to the monitoring of receiving monthly data from our Learning Collaborative participants in Region 4. However, we are encouraged that while more data is pending, our 5 Learning Collaborative providers are reporting lower UTI serious incidents among their agencies. So this is promising for when we expand the Learning Collaborative information across the state, which we do plan to do by the end of this month. Now, the Learning Collaborative structure is designed as a trainer model, and it fosters a culture of continual learning and quality improvement. So the numbers that you see following each topic, that is the total combined number of staff trained between all 5 providers. So our Learning Collaborative participants were very proactive, and once they learned the information, they took it back to their agencies and they immediately began to train their staff. So some of our plan to promote improvement over time, as I stated, is to continue monthly data collection until April 2025. We just feel like we needed to have a whole year of that monitoring to kind of go with our initial monitoring that we started with our baseline. We started with getting information from our providers over the previous year. So this will give us another year measurement to compare to the initial. And as I stated earlier, we will expand the UTI Learning Collaborative information statewide, and we plan to do that through the Provider Network listserv. Next slide, please. So I have a treat for you guys. Next up are 2 of our Learning Collaborative participants, Maria Nojane and Laura Chitwood, with Counseling and Advocacy Associates, who will share some information and their experience with the Learning Collaborative. Maria and Laura.
Thank you so much, Pebbles. I'm going to go ahead and start. If we could switch to the slide that should have our storyboard on it. Awesome. Okay, so what you're looking at here is kind of our final project, I guess you could say, where we just wanted to give a visual to what we did. So We are a provider of sponsored residential services. We do serve a vulnerable population to UTIs. So through this collaborative, we use the Plan, Do, Study, Act model to look at not only what we were already doing in terms of the topic, but also how our staff members, our sponsors, and our individuals were also trained on these, trained and assessed on these different topics. Um, so in the first topic, our hand washing, never knew all I did not know about hand washing properly. So we took that, and not only did we train our sponsored residential staff members, but we also trained our entire agency as part of our infectious disease training protocol. We also added, thank you to Maria, a lot of nice items to our bathrooms to encourage proper hand washing, such as, scented soaps, pretty towels, nice lotion to prevent dryness afterwards. It was wonderful. For our next topic, it was perineal care. And right away we realized, oh, some of our clients, we're not, or the individuals we serve, we're not actually sure if they fully are able physically to complete their own perineal care. So we really started that with a thorough assessment, specifically of perineal care and who needed partial, who needed full assistance, and who did not need any assistance at all. The third topic was My Care Passport, and we did some assessing there, got some feedback on the My Care Passport, and found that some of our individuals were not a huge fan. So we took the feedback that the individuals provided us, and Maria made what she calls a one-pager that provides similar information that many of our individuals are using. And then, okay. And for the final topic, it was clean urine catch, and we approached that very similarly to the perineal care, where we assessed who needed full assistance, partial assistance, or who was able to complete a clean urine catch independently. And for this, we also drew on some of our nurses who are on staff as sponsors to assist us in developing a training protocol for the other sponsors. And with that, I'm going to turn it over to Maria.
Okay, so what we learned is a couple things. We learned that our staff was doing amazing things and things I did not even know that they were doing. So for example, the perineal care, I didn't realize all the strategies they all had in place. I thought I was going to teach them about things to do, and they taught me. So what I also learned is that this collaborative model transferred over to how I now teach my staff. My nurses didn't want me, I'm not a nurse, to teach them about these things, but they were willing to come to a collaborative conversation and use the materials that the UTI collaborative provided me. And now they help teach my staff that also need it. So it spilled over to how we teach at CAA. Like Laura said, the hand washing spilled over to the ABA clinic and mental health skill building, and even our sponsor residential clients that were able to understand and wash hands independently. They were also trained. The My Care Passport that we talked about, I did make a shortened version, and it's very person-centered planned. I'm also a positive behavior support facilitator. So when an emergency, if a rescue squad comes to the door, you give them that one pager with a copy of the client's medication, and that person can scan that material and quickly understand some of the limitations or support that the person needs. The advocacy card that was provided to us about different tests that individuals should receive when they have signs of a UTI or other things that aren't that I'm sorry, I'm trying to think of one, seizure or other things, also was very, very useful and has been used multiple times by my staff since the training. And so again, this one topic spilled into other things. What we also learned is because sponsored residential changes and our numbers grew or people left, that also affected our data that we could not control. We learned a lot of just science about UTIs, and some UTIs, some people are just prone to them and they're atypical. So that was super useful as well. The resources, and as the collaborative went on, the resources got easier. These QR codes for my staff to go right to a training meant, I don't have to do the training. They can go to the training and then we can have a collaborative conversation afterwards about what they learned, which my staff respected that's how that they were being trained. They respected that they were seen as a professional, that they were collaborated with and not just talked at. I'm thinking, and I think in the end, what we learned is that we could take the model that they showed us, the PDSA model, and transition that to things that we wanted to use at CAA, things that we needed to learn, develop to make us better at CAA. And so overall, we got a lot more out of it than just the data that you're seeing on the screen.
Great. Thank you guys so much for being here. I told you guys they were special guests, and we really appreciated all the work that they have done in response to the trainings in their organizations. Thank you guys. So the next slide, please. So what did we learn? The first thing that we learned is plain and simple, is that solution resolution can take a while to get to. And as some of the previous presenters have demonstrated, we go through all these different things. We did the driver diagram, as you had seen earlier, and you realize just from that, there are many factors to consider, which took us weekly meetings over multiple months in order to finally get to a product we believe was useful and practical. But what's even greater than that is that the interventions can be instrumental to improving the content of individual protocols, as you just heard from Laura and Maria. So as well as developing competent and UTI knowledgeable direct support professionals. So that was one of the greater learning components. So what we really love about the learning collaborative structure is its interaction and engaging components. So to keep those components vibrant, we limited our training sessions to 90 minutes each month, and this assisted in facilitating that greater learning experience. Next slide. So these are just some of the tools and resources we utilize. There's links down there also for the DBHDS websites where the UTI Learning Collaborative training can be found. Next slide, I think that's it. Is that the last slide? Yes, but as a final note, I would like to thank the entire team for their tireless efforts on this initiative. I want to give a special thank you to Mary Beth Cox for introducing us to the concept and structure of the Learning Collaborative. Our OIH, Office of Integrated Health experts, developed some phenomenal content for each of the topics and conducted the trainings for us as well. And of course, we could not have done this without the providers who participated in the Learning Collaborative. So thank you to all.
Thank you, Pebbles. Thank you so much. And thank you, Maria and Lauren. That was fantastic. So fantastic to have you here as part of the showcase. I wish we could have had all of the providers. Maybe next time we'll do that at the end of our next Learning Collaborative. I'm a huge fan of the Learning Collaborative model, so hopefully we can find a way to do another one. And definitely if you're, even remotely interested in UTIs, hand hygiene, go check out this last link on here. Like I said, I'm going to be sending out all the slides, so you'll have that information. So thank you so much, Pebbles. We're going to move on. I know it feels like we're going very fast. I'm going to remind everybody. I saw there was a question in chat. Great job. Gold star for the first question. Please, others put your questions in there and we'll queue them up. So now I'm going to invite Eric Williams to share his presentation. Eric is the director of the Office of Provider Network Supports. I know he is also an acting commissioner, and I forget the exact title. Maybe he can tell us all. I'll turn it over to you, Eric.
All right, thanks, Mary Beth. Acting Assistant Commissioner of Developmental Services right now as well.
Thanks.
So I'm here to share just very briefly, kind of walk through the QII that the Case Management Steering Committee implemented around improving SC retention. So in terms of Case Management Steering Committee members, on the next slide, you'll see that we have 6 core members that participated. Myself, Julie Palmer, who was a community resource consultant at the time. She has since left DBHDS, but she was integral in setting up the focus groups along with Mary Beth and others in getting the QII off the ground. Kim Snyder is now our team lead for Team 3, which is our system team in the office. Also from quality management, we had Mary Beth, Ramona DeFonza, and Christy Lambert. Carrie Hennessy is our quality research specialist, and she helps a lot with everything that has to do with numbers. So we are always very appreciative of her. We also want to thank the support coordinators who participated in the focus groups and who completed the survey. I think one of the unique things about this QII is we did have a good amount of actual support coordinator participation in the process, which was really key to helping us get the right information. So we'll jump on to the next slide and I'll give you some background. So we know that support coordinators and case managers play a pivotal role. They also have a very challenging job and a very critical job in terms of the DD system of supports and services. In 2021, staff retention was cited as the #1 concern from the regional quality councils. And while this has been a long-standing challenge, which is just the retention of staff in general, we went back to 2018 and looked at a VCU report on the status of case management statewide. And we learned through that report that at the time, the turnover rate among case managers at CSBs was 28.2% over the previous 12 months. And at some CSBs, turnover was as high as 75%. So clearly it was a concern that we wanted to address and try to make a difference around. So the root causes were related to the workload and employment trends and conditions that were exacerbated by the pandemic. All right, so we jump on to the next slide. I'll talk about our model for improvement. So our aim, our baseline was 71.8% retention in 2018 based on the VCU report, and we hoped within 1 year to reach 86%. We're not there yet, and the QII is still open, but we'll talk more about that in a second. So our measure was to measure SC retention quarterly using WAMS data. It turned out that we weren't able to do that. Part of that reason was once we dug into the data, we understood that sometimes support coordinators would leave employment at a CSB and their assignment in the system wouldn't immediately get updated, which brought into question the quality of that data and our ability to use it. So what we ended up doing was surveying supervisors to basically determine how many SCs as of 9/1/22 were retained and still in their position as of 9/1/24. So we used a survey process with supervisors to get that data. Our change was to hold focus groups with support coordinators to identify challenges and solutions. And then our second change was a little bit different. We wanted to have a bigger impact, so we actually identified 7 changes that could sort of be packaged together to try to make a difference in the workload of support coordinators. The next slide is going to kind of show you a high-level overview of the QII. You'll see some of the themes there in yellow that came out of the focus groups. So reducing excessive and duplication of paperwork was a concern. Making sure providers are accountable to do the part of the work that they need to do, and then improving efficiency and work-life balance. We did use a pick chart, which I'll talk about at the end of the slideshow, in terms of prioritizing themes and ideas. The 7 changes we implemented over 2 years include reducing the on-site visit tool use for targeted case management to once per quarter. We discontinued the use of the individual planning calendar in WAMs in November of 22. We clarified and simplified enhanced case management guidance in December of 22. We reduced requirements for SEs to participate in RST meetings to an as-needed basis instead of routinely. We did that in 23 in February. We clarified employment discussions were not required for youth under the age of 14 or adults over the age of 64. We also developed and implemented with the system team an SC 101 training in June of 24, which was rolled out and introduced to all the CSBs statewide. And then we clarified and simplified our DDSC handbook in July of 24. So once all those changes were done, we set out to evaluate the impact. And the way we did that was we conducted a survey of support coordinators about each change, as well as the package of changes. And then we also asked the supervisors for the retention data as well. All right, we'll jump on to the next slide. These are the results for each of the changes based on the survey data. The blue here represents that folks thought the change was helpful, and the green represents the percentage that said it made their work easier. So you'll notice across the board, changes were perceived as helpful at least 70% of the time, up to as high as 92% for the package, 89% for the discontinuation of the planning calendar. I heard that one CSB cheered the day we did that. So that one definitely had a good impact. The SC handbook, making it easier, had the lowest impact, but still was considered helpful. So it looks like individually and collectively, the changes we implemented did help folks, which was good to see. So on the next slide, this is the percent of original SCs that were aware of the change. So the individual planning calendar, again, had the highest percentage at 84%. People really noticed that and were aware of it. The lowest was the SC 101 training. So I imagine that's still, we're still in kind of the early phases of getting that introduced. CSBs have taken that training and are using it internally. We're also looking to offer it on a routine basis through our office to help CSBs out with their workload, but by providing some ongoing training for support coordinators from central office. All right, so we'll jump on to the next slide. The SC retention over the past 2 years, we looked at from 2022 to 2024. You'll see the result there is 65%, so it's actually below the baseline of 72%, which we saw at VCU. We had 29 CSBs respond out of the 40, so we had a 73% response rate, which is a limitation because it doesn't show us the impact at all the CSBs. That's kind of our outcome in terms of data. On the next slide, we'll take a look at our conclusions. So even though we didn't achieve our aim of getting to 86%, we did identify that the changes we implemented both individually and considered together were helpful to different degrees. They were helpful. In some cases, it made work easier. In some cases, it was just perceived as helpful. I think people appreciate when you make an effort to help increase the manageability of their work. It's not possible to know whether or how the changes impact retention because there are a lot of factors that go into retention and people changing jobs. So we're not clear exactly on the impact there. The response rate to the SC and CSB surveys, the results may not be representative because we didn't get every support coordinator, we didn't get every CSB. We also don't have the input of support coordinators who left employment as CSBs. So we want to recommend that we increase our efforts to ensure that SCs are made aware of important changes that impact their role in jobs. So when we communicate information out, making sure it gets to the right people, and then to continue to explore additional opportunities as sort of a phase 2, this QII, we may produce a new QII to continue to strive to make streamlining changes and changes in the workload to improve the retention of support coordinators across the system. So the next slide is going to show what we learned. So we learned that it's really important to engage people directly involved and impacted by the problem. So the level of actual support coordinator participation in this QII was key to it being successful. Really hearing from people doing the work, what their challenges are, what their struggles are, and then tailoring our response to what people need was important. The focus groups were the vehicle through which we were able to collect a lot of that information. All right, on the next slide is the tool we used. So a pick chart helps the team rate ideas based on difficulty, which is easy to hard, and payoff, which is low to high. So you'll notice the X and Y axes on this image. You have payoff on the Y-axis and difficulty on the X-axis. And you analyze your ideas by 4 categories. So is it possible? Which basically means it's low payoff, easy to implement, right? And then implementation, which is above that, is a high payoff, but an easy effort. And then kill is, well, let's go to challenge. Challenge is a high payoff and high difficulty right there. And then kill is, it's really hard to do and it's not much payoff for us. So low payoff. So you just take your ideas, you put them on sticky notes, and as you talk through your ideas, you make decisions about where they live. And when you're finished, you list your ideas in the table at the bottom of the chart. It's a really helpful way to kind of figure out what to pick up next and what to do. So I think that might be the end of the QII. And thank you very much.
Great. Thank you so much, Eric. And if anybody has questions for Eric, please put them in the chat. I know there were a lot of interesting pieces of this one as well, especially that there were 7 changes in one. The challenge of evaluating that for effectiveness was real, but we did it. We did it. And next we have Danica Goldman, who will be sharing the Improving Seclusion and Restraint Reporting, which was a project of the Risk Management Review Committee. So thank you for being here, Danica, and I'll turn it over to you.
Okay, thanks. Can you hear me okay?
Yes, we can hear you.
Excellent. All right, so we'll jump right into the next slide. Yeah, there we go. So I am talking about the QII about improving submission and responses related to seclusion and restraint, but the team's most important. So I want to start there. The team working on improving seclusion and restraint reporting QII was a mix of staff from different DBHDS divisions and included people who engage with data in general, providers, and specifically the use of seclusion and restraint in different ways. I do want to acknowledge here that it was important for the Office of Human Rights to have representation from every role on our team, because we know that any initiative that's going to be successful not only requires buy-in at every level, but also varied perspectives. And so it was also important to think with the end in mind about how we wanted to use and communicate this data. And so Susan and Martin really helped to keep focus on our different audiences, while Ariel and Mary Beth did the same, but specifically about our procedures and our messaging. So then the next slide, by way of background, the human rights regulations require that DBHDS licensed providers submit an annual report of each instance of seclusion and/or restraint, literally by January 15th of each year. After about 2 years of using a survey to collect this data, we were still pretty disappointed with the low response rate. So besides the fact that it's a requirement, the problem is that without all, or at least the majority of providers reporting, any analysis or really any hope for system-wide application and problem solving is lost because the data is not comprehensive. So before we move on to the next slide, you may have noticed language beside the requirement for annual reporting that reads, or more frequently if requested by the department. This begs the question, how else is seclusion and restraint reported to DBHDS? So the answer is that providers are also required by other sections of the regulations to report their use of seclusion and restraint in real time. They report to the Office of Licensing when there's an injury resulting from that restraint or seclusion event, and they report to the Office of Human Rights when there's a complaint made by or on the behalf of an individual receiving services, or the provider might discover on their own, possibly during some kind of a look back review, that that restraint or seclusion was unauthorized in some way. So that means the staff was using the wrong technique, or maybe the individual wasn't really in imminent danger. So I wanted to make that clarification. Next slide. So prior to getting to the initiative part of the QII, we performed a root cause analysis based largely on key informant interviews, which really helped us to identify some of our baked-in barriers to achieving a higher response rate. We'll talk more about the key informant conversations on a future slide, which was really one of my favorite parts of the process. You can also see here some of the initial barriers identified as issues with communication, lack of clarity, and then concerns about why the data is meaningful and why it's needed. The next slide. Our model for improvement set our aim to increase the provider response rate from 48%, yes, that's what it was, in calendar year 2022, to our goal, which was 86% for calendar year 2023. The numerator for the measure was the number of provider services which have an annual seclusion and restraint report submitted, and the denominator was the total number of licensed provider services. And spoiler alert, the change hoped for and achieved was an improved process for issuing the survey and improved communication strategies, which was really twofold. We improved communication regarding what, when, why, and how to submit annual reports, but also published a summary of the results on our website as a form of communication afterwards. The next slide. So what did we do? The team met bi-weekly, and we spent a lot of time mapping out our existing process step by step to, again, identify what we were currently doing and talk through these specific areas where we already knew we might want to improve. The Office of Human Rights staff on the team conducted 10 key informant interviews outside of those meetings, which really informed most of the changes we made and ultimately changed our process. We'll talk through these steps over the next few slides, which really includes kind of a snapshot of the pre-process and a snapshot of the post-process, which is exciting. The next slide. For me, doing the key informant interviews was the most fun and truly informative part of this QII. Really because at any level, when the Office of Human Rights is reaching out to people, it's usually because there's something wrong or something serious. And so having the opportunity to speak firsthand with providers was really meaningful. We wanted to make sure that we didn't just naturally gravitate to talking to the providers who didn't submit anything, right? That's kind of a no-brainer. Like, what did you do? Why didn't you submit it? But we wanted to talk to all of the response types. So the providers that submitted everything perfectly and on time, something for every service. We wanted to talk to the providers who submitted it late. We wanted to talk to the providers that submitted just one service and ask them questions about why they didn't submit for the rest. So it was really a mixed bag of all different types of responses. Some of the challenges that providers were able to freely identify presented a lot of opportunities for us to improve communication. You'll see there kind of in the middle some of those challenges, and on the right some of those suggested solutions. Providers explained how they were really unsure about whether or not they received the email that we were sending out. They weren't sure about the requirement or the process. Some were unaware that they had to submit for each service. Some of the providers honestly just admitted they forgot, or admitted they didn't know, or that the person that was doing it for the past 3 years was no longer there, and the new person either didn't receive the email or they didn't know how to submit it or what to submit. So some of the suggested solutions included sending out more reminders, providing education about the requirement, and training for how to submit a response. They suggested using Connect to send communications to staff because Connect is the licensing database that they're already used to using and already used to getting communications through and sending them through. They also made suggestions about more information on our website about when it's due and how to submit that information. I also really appreciated hearing how the providers who were doing things right also had suggestions, right? They said one of the things they did was not just train the staff person who is their QI person who should be doing all this reporting, but they trained everybody. It was important to their entire organization that everybody knew what this requirement was, how to submit it, and when it was due. And that really helped them to avoid reporting issues in the future. Next slide. This infographic describes the initial process, there we go, that the Office of Human Rights was using to collect our annual seclusion and restraint responses. As a disclaimer, I'll say that the Office of Human Rights is small but mighty, and a lot of our focus really is on responding to complaints about abuse and neglect and other human rights issues in real time. And to that end, we were a bit more focused on the regulatory requirement to just ensure providers submitted the data, and we didn't have much of a focus, or in reality, resources directed to what we wanted or could do with the data after we received it. So the process involved issuing a memo to providers around December about the requirement that included a link to a survey and a reminder that it was due by January 15th. We were sharing this information via a listserv based on a list of licensed providers through Constant Contact. We were running a report from Connect to identify all licensed providers and licensed services for the year so that we would know who we were expecting a response from. After we closed the survey on January 15th, we worked intently over the next few months to clean the data. And then, in all transparency, we checked the box that we collected the data, and that was that. Next slide. After we took a look at our existing process and started to think through questions like, what do we want to know from this data and what should we be doing with it? We also started to tinker with that process and consider how to interject the feedback from our key informant interviews. And so the result of thinking through all of these things is really the additions of those, I was going to say bubbles, but they're like blurbs, the blue blurbs that you see. That's how we revised our process. And essentially the changes included making the memo we send in early December clearer about the requirements and easier to read. So it's just not a lot of regulatory language. Notably for us, the realization that sending communication through Connect was not possible. And so we made sure to direct providers in those memos and communications to make sure they had up-to-date contact information in Connect. And we used that list of providers to send our communication through Constant Contact. We also created specific training about how to submit the survey response and a section on our website dedicated to the requirement and the process. We received the survey, we revised, the survey form to make it easier to report multiple services and 0 instances, including a reminder at the end of the survey, which was a whole new link that if you had another service, click here. We revised, thank you. We had a huge takeaway from this QII for our office in revising kind of the ways that we were looking at the data and what we wanted from it. And so we were able to come up with different ways to summarize the results. And that's the other way that we closed the loop. We sent that information back out through Constant Contact and put it on our website. What's not listed here is a secret, so I'll tell you. Please don't tell folks. One of the things we got from feedback was that providers kind of, for whatever reason, got back after the holidays and January 15th kind of snuck up on them. And so we actually didn't this year or the year before just close the survey right on the 15th. We kept it open for a couple of days so that if a provider got that reminder email late, they still had a little bit of a grace period to submit their information. All right, next slide. The results were an increased provider response rate. Although we didn't achieve our end goal of 86%, we're super proud of the improvement, which was just shy of 80%. On the next slide, we'll talk about what we learned, and I'm happy to say that the most of the improvement process strategies were easy to implement, and we're doing it right now. We're kind of in the middle of collecting for calendar year 2024. And as of today, we're at a response rate of 44%, which is like 3% higher than our end result a couple of years back. And so all the reports are due on Wednesday, but based on our secret, they've got a couple of more days, so don't tell them. We actually also sent out a reminder this morning. So regarding what we learned and any advice that I'd like to pass on, our team really enjoyed doing the key informant interviews, if I didn't say that enough. As I mentioned, we really are having conversations when things are bad. And so it was nice to be able to honestly hear their challenges without them being afraid of getting a violation letter or a citation. The advice I have here, besides just doing it, because I think they're really meaningful, is to have a script and to build in time for off-script conversation. Because I wanted to make sure that we kind of got all the information we needed up front, because based on whatever it was they said, I was pulling that thread. And so the conversation could be as short as 20 minutes or as long for me as an hour and a half. So making sure you've got a script, people understand why you're calling, you get what you need up front, and then any loose ends you can take care of at the end. The process map was also a helpful exercise. It was key in helping us to see some of the barriers that were kind of baked into our process. So for example, we were relying on using Connect system for communication. And when we started writing out these steps, we realized it wasn't working. So my advice here is really what happened after we identified the issue. We reached out to include a new member of our team from the Office of Licensing who specialized in the Connect system to help us work through that and come up with real, practical, doable solutions. So my advice is that if you're in the middle of something comes up, reach out to the people who are the best resource to solve that problem. You're not just stuck with the original team members that you identified. And I feel like next slide, yeah, this is going to be my last slide. It's just intended to offer some additional resources for developing your own QII. Again, what I love is the key informant information. And then if you had more questions about the use of seclusion and restraint in our system, you want to see that summary that I talked about, or get access to any of the trainings we provide, you can go to our website, which is linked there, and then also the human rights regulations. And I think that's it.
Tanika, thank you so much. I know I always kind of brag on this one as I think it had the highest improvement of any QII to date, from that 48% to 80%. Definitely something to brag about. All right, so we have one more presentation. Last but not least, I will tell all of our attendees we will probably go past 11:30. If you need to leave, we understand, but if you can stick around, we would love for you to stick around and listen to Britt Welch talk about improving compliance with some licensing regulations. So
Thank
Britt, I
you.
will turn it over to you.
Thank you, Mary Beth. Again, my name is Britt Welch, and I serve as the Director of the Office of Community Quality Improvement. And this particular QII is related to the 520 and 620 regulations, which has to do with risk management, which are the 520 regs, and 620, which has to do with the quality improvement or quality management regulations. Next slide, please. So just to give you an idea of the team for the Risk Management Review Committee, we have Dr. Dave Nair, Mary Beth Cox, Mackenzie Glasgow, Karen Matthews, Alex Trumbull, and Jessica Sprouse, along with myself. Next slide, please. And to give you a little background, I would be remiss if I did not let you know that I have two teams in the Office of Community Quality Improvement. Team one consists of Jamie Roop, Ramona DeFonza, Christy Lambert, Pebbles Brown, and Ricky Jones. And so much of the work that our current team, my second team, the ECTA team, is doing is based off the consultation and technical assistance work that Team One did to lay the foundation for us to even have ECTA. In other words, we did a pilot project in which we looked at doing consultation and technical assistance on just one of the regulations that licensing had identified was problematic for an awful lot of providers. That was regulation 620C2. That has to do with providers' quality improvement plans having measurable goals and objectives in the plan. We had a great deal of success with the pilot, and then when we launched statewide, we continued to have success, so much so that we were asked to expand the number of regulations within the quality improvement and risk management array of regulations, that we expand that to cover more of those regulations. Now we fast forward into the Risk Management Review Committee. We have a performance measure indicator that's tied to the settlement agreement, and that indicator looks at the percent of licensed DD providers that are compliant with 100% of the 520, 620 regulations. The goal there, of course, is 86%. Some of the problems that have been encountered was the Risk Management Review Committee had been tracking this particular indicator for over 3 years, and the results were always below 60%. And of course, our goal is 86%, so something needed to be done. And then the Office of Licensing does a great job of providing training, developing tools and resources for providers. Yet we were still having issues with the findings or the results of reviews being done on these regulations that, again, were below the goal of 86%. Now, some of the root causes that we've identified is that not all providers benefit from large participant trainings or venues. And when you think about it, when you could have upwards of 500 people in a licensing training, for example, and that venue does not lend itself to an open dialogue back and forth of question and answers. Another root cause that we found was there was a lack of understanding about the subject regulations. Then providers often had difficulty finding the risk management and QI resources on the website. And when they did, it's confusion over, well, how do I apply this? And then there was limited provider knowledge on the collection and use of data to risk management and quality improvement. Next slide. So our model for improvement, our aim with this QII is by December of 2026 to have 86% of DD licensed providers meet 100% of the 520-620 licensing regulations. Our baseline from the data that we had from calendar year 2023 is 56% for both regulations. We have basically two measures that we look at. One, we have some preliminary data that we get off of the ECTA experience surveys. I'll talk a little bit more about that in a minute. And that's to give some immediate feedback to the team in terms of how we're doing and where we might need to make some improvements. But ultimately, where we find out how providers are doing is going to be at their annual licensing unannounced reviews for 2025 as well as 2026. The changes that we implemented, we're using a truly consultative approach in our model. And with enhanced consultation technical assistance, we meet one-on-one with providers. And I think a key here is that we tailor the information, the tools that we're going to share with them and help them to hopefully better understand is tailored to the individual needs of that provider. Other changes, we're forming good working relationships with providers. We assess providers' understanding and their application of the risk management and quality improvement tools and concepts. We drive providers, well, this is very key, we drive providers to those applicable licensing and risk management tools that are on the licensing website. And then we also demonstrate how do you even use these tools? What are these? We help them to better understand what the QI principles, risk management principles, and concepts are about and how they apply to their organization and with the regulations. Next slide, please. So in terms of what we did, we hired 10 QI specialists and 2 QI specialist supervisors. We asked licensing specifically, we had McKinsey and Karen come in, and they provided intensive training on the 520 and 620 regulations. Not that we were to become licensing specialists, but rather if we had a good understanding of those licensing regs, it helps us understand how those tools, how the concepts and the principles apply to those regulations. We also developed a readiness assessment as along with an ECTA experience survey. And Mary Beth was just critical to us in being able to develop both of these tools. So with the readiness assessment, the provider assesses themselves and where they are with their understanding of risk management, quality improvement, tools, concepts, data literacy, for example. They give us that assessment. And then we have an experience survey such that when we complete ECTA with a provider, we send them a survey and then they're scoring themselves on what that experience was like going through ECTA with us. A part of that survey, we've integrated before and after questions. So before ECTA, how did you feel about whatever the topic of the question is? After, how do you feel about that? And we'll share a little bit of that, of some of the information we've gotten in just a second as well. Then we also developed a structure that included eligibility criteria for providers. How the structure includes contacting providers and logging those contacts, because that's important for us to go back and review that information. We also developed a time estimator. So with each of the subject regulations that we have an estimate of how much time we believe we will be spending in ECTA. Now, we're not just going to rest with that estimate. It is truly an estimate. So what the what the QI specialists do is they come back in and they indicate the exact amount of time that they spent on each regulation working with a provider. As we could continue over time, that will then allow us to come back and get an average amount of time spent on each regulation. So we have a much better idea of just how much time a particular regulation took for us to work with that provider. We also developed I call it a soup to nuts flow chart, from being able to identify, getting data reports that helps us to identify providers that are eligible, all the way through to sending out that experience survey. We also do a travel and expense log, so we want to make sure how we're stacking up against our budget for providing the service. And then we continue to look for ways to improve our process, and we do that through a couple of different ways. One of which is that each of the teams, we have an East team and a West team, but they have weekly debrief sessions with each other to talk about how did the week go with providing consultation and technical assistance to the providers. We also have an ECTA management team that we have weekly meetings there that we can discuss any areas that may be problematic, areas that are going really well, et cetera. Again, all that is geared towards how do we go about improving the process. Thus far, we've worked with 68 providers that have completed ECTA, and we have 217 that are in process or assigned. Next slide, please. Our ECTA teams, you heard me talk about having two teams for ECTA. We have a Western Territory and an Eastern Territory team. In the Western Territory, Kara Clemens is the Quality Improvement Specialist Supervisor. On her team are Leanna Craig and Jordan Hyde in the Southwest region, David Cruz and McKinley Harris in the Western region. We do have a vacancy in the Western region, which we are in the process of recruiting for right now. The Eastern Territory, Tina Harris is the Quality Improvement Specialist Supervisor. On her team are Lisette Bennett and Lauren Gibson covering the coastal region, Sophia Dunn and Irvin Good covering the central region, and then Andrew Williams is in the Northern Virginia region. Next slide, please. And I mentioned our survey results. It's still a bit early. We continue to get survey data in, but thus far we've had 60 responses from providers. 88% to 100% feel more prepared to be compliant with the 520 and 620 regulations. More providers are feeling that they have a better understanding or are more knowledgeable about the difference between quality insurance and quality improvement. This is a really important one to me. I know in my own experience, when I was first getting into quality improvement, I thought I knew the difference between quality assurance and quality improvement. And the further I got into it, the more I realized while the two are certainly tied together, there are distinct differences, both in terms of the philosophy of them, along with what tasks were associated with them, but they are tied together. But here, I had mentioned on the survey, we have some before and after questions. So before ECTA, we had 32% of our respondents that said that their knowledge of the difference between QA, QI was very good or excellent. After ECTA, we have 83% that said their knowledge of the difference between QA, QI was very good or excellent. We have 90% that strongly agree or agree that ECTA has met their expectations. And then we have 97% that would recommend ECTA to other providers. Next slide. In terms of what we learned or what advice we would give, this has kind of become our mantra, but meeting providers where they are and not demanding they be where they are not, it works. Going into this, we knew that there were going to be providers that were going to be in a position where they could really leverage a lot of technology to the point that they could virtually push a button and run a data report, get analysis of that report and what it means for quality improvement and risk management. And then we're going to have other providers that they got a pencil and they got a pad of paper. And I'm very pleased to say that the team can work with either of these groups and anyone in between. And that's because we really try to meet providers where they are. I would also suggest start small and get a win under your belt, because winning breeds winning. And so when the team started out, it was important to me that not only are they learning the tools and how to apply the tools and that they have a comfort level with that, but that they are also, I'm sorry, would you go back to the other slide, please? Thank you. But that they're also developing their style of how they go about conducting ECTA. And so again, you want to get that win under your belt. Also, we set expectations. We developed a structure to accomplish our mission, and then we trust the process. So in other words, when you start out doing a quality improvement initiative or you're starting a new program, you plan it out, and there might be something that you weren't anticipating. Well, sometimes your reaction could be to, oh, we got to change everything. Well, no, that may have just been a blip on the radar screen. And you can pretty much expect it's not going to go according to plan. So you want to monitor stuff over time and allow yourself the flexibility to make changes when it is necessary. So that goes back to the meetings that we have. We're looking for what kind of things need to be improved and when do they need to be improved. Then the other thing we learn is to take joy and have fun in what you're doing. And so I've emphasized this with our team is that if you're having fun with this, that will come across to providers and it will begin to take the boogeyman out of whole risk management quality improvement. It just comes across to them. And really, when you think about it, quality improvement is a journey. And the journey can be awfully fun if you take that attitude towards it. And so to give you an idea, these are the tools and resources that we utilize throughout the provision of ECTA, depending upon what the needs of the provider are. You'll notice here that if it has an underline under it, like the fishbone diagram, et cetera, those are active links for you. But I've highlighted the ones that we are going to most frequently at this point across the providers that have completed ECTA. And so here you see the list comparing quality assurance versus quality improvement, the fishbone diagram, the risk tracking tool, the SMART goal and worksheet. We get an awful lot of traction out of that SMART goal worksheet. And I think it provides what we call those aha moments for providers when they're able to make that connection about what they've been struggling with. And now it all comes clear to them. They get it. They understand the concept and what's supposed to happen. The run chart and then the risk matrix would be the other tool, I think. And I think that wraps up my presentation there, Mary Beth.
Yes, thank you. Thank you, Britt. Thank you so much. And
Thank you.
I think that that's actually a good note to wrap up our presentations today. Is about having fun, right? Taking joy and having fun in what you're doing. I would venture to guess that all of our presenters today would say that they had fun doing these quality improvement initiatives. Now, if you presented, you could give me a thumbs up if that's true. I think it's fun. Well, this might be my nerdy side showing. I think it's fun to use data to see if you're improving things and figure that out, right? Do all the problem solving and fun to work with teams and get to know each other on a closer level and work together to figure things out and fun to try things out and see how they go. And yeah, definitely. I'd say quality improvement is fun. That's one of the reasons I love it. So I know we are past time, and I think we had one question in the chat, so I want to make sure that we get that addressed. Ramona, do you want to pose the question because I can't find it right now?
Yes, certainly. Hi, everyone.
Thank you.
Siobhan Walsh had asked if does DBHDS in general have a hand washing policy, or are those procedures at the facility level? And I don't know if someone from RMRC can respond to that, or Pebbles.
Well, I can say personal. Well, go ahead, Bubbles. I saw you unmuted.
Well, yeah, I can't really speak to DBHDS having a policy for that. I don't know if there's something maybe still in licensing. I don't remember exactly what that looks like. But most times it does seem like there is something at the provider level. What did you have, Mary Beth?
Well, I was going to say the same thing, that I don't know about having a policy or maybe a model policy somewhere. We can definitely look into that. But the Office of Integrated Health has health and safety alert about hand washing or hand hygiene. And if you go to that link that Pebble shared about where all the UTI information is, there's videos and handouts about hand hygiene and the cool activity we did, which involves like a black light to see if you've washed your hands adequately. It was so much fun. So definitely check out those resources. Ramona, did we have any other questions?
We just have one right now. That is there a comprehensive list of tools used to analyze the qualitative data collected across the different initiatives?
A comprehensive list of tools used to analyze qualitative data. I would say we don't have that. We do have a number of tools that I think Britt's list was really great, and it has the live links for tools that teams can use to do quality improvement projects. I think that's different than what you're asking, but in terms of tools, that is something that we do have. And I will be sharing the slides from today, so you'll have the information about the different tools that the teams recommended, along with the links that they shared.
And Mary Beth, would it be fair to say that if someone feels as though they didn't get something answered even after they look through everything, to just reach out to you directly for us
Yes,
to follow up? Okay.
yes, definitely. And again, my name is Mary Beth Cox. It's marybeth.cox@dbhds.virginia.gov. You can email me, and I will try to help you or find somebody who can. All right. Well, we went past. I want to thank everybody who has stayed on to get the full benefit of the presentations. And I want to thank Ramona for helping me out and all of our wonderful presenters today. Such a great array of projects, such tremendous work that's been done through these and the other QIIs that you didn't even hear about today. And please check out the comments. You're getting some great feedback here. So with that, I'm going to stop sharing and go ahead and conclude the webinar. Thanks, everybody.
Thank you. Bye.
Bye.
Thank you so much. Have a great day, guys.
You too.